Welcome back to Core EM, the official podcast of the NYU Bellevue Emergency Medicine Residency Program. I'm Brian Gilberti, and today we're joined by Dr. Catherine Jamin. Dr. Jamin is an associate professor of emergency medicine and vice chair of operations in our department, along with being triple boarded in emergency medicine, internal medicine, and critical care medicine. Thank you for joining us, Dr. Jamin.
Thank you, Brian. I'm excited to be here.
So we're very happy to have you on the show to help us dissect a topic that is both essential to our practice and a bit nuanced, vasopressors. There are a couple of main agents that we reach for to provide additional pressure support to some of the most critically ill patients that we see in the emergency department. But before we start talking about what's in our toolbox, Dr. Jamin, can you give us a bit of an overview of these medications and when we should consider using them?
Absolutely. When we think about increasing the blood pressure, there's two primary mechanisms of accomplishing this for our purposes. One is through increasing the systemic vascular resistance by inducing vasoconstriction, and the other mechanism is through increasing cardiac output by augmenting inotropy and chronotropy. Some of the medications that we're going to discuss act purely via one method. However, many act through multiple pathways. We should be thinking about starting vasopressors anytime we are worried about a patient perfusing their organs. Often, we use the measurement of a MAP less than 65, a systolic less than 90, or blood pressure significantly decreased compared to baseline. While I don't personally have a hard cutoff for this, I look for any signs of organ injury such as altered mental status, decreased urinary output, or an elevated lactate. An additional consideration is whether or not a patient can tolerate fluids and whether or not they're going to be responsive to fluids. If we have concerns in either one of these categories, just another reason to start pressors sooner rather than later.
Okay, so let's say we have a patient that checks some of those boxes, and we're at the point where we're pretty sure we're going to have to give one of these agents. Walk us through which vasopressors we typically use in the emergency department, and if there are situations where one is preferred over another.
The pressors that we typically use are norepinephrine, epinephrine, vasopressin, and phenylephrine. In cases where we are concerned for a primary cardiogenic component, we will give inotropes such as dobutamine and milrinone. Norepinephrine is our go-to pressor for most cases of shock. It is first line for septic shock. It's a good choice for hypovolemia while we restore volume, as well as cardiogenic shock with severe hypotension. In cases of undifferentiated shock, which is common in the ED while we work on the diagnostic testing, norepi should be your first choice.
Okay, so sounds like norepinephrine is going to be our all-around solid vasopressor. Now let's start going through these one by one and tell us about the mechanism of action, starting dose, maximum dose, and some pearls, starting with norepinephrine.
Norepinephrine stimulates our alpha-1 receptors, which results in vasoconstriction. It also stimulates our beta-1, which is going to give us chronotropy and inotropy. This makes it an ideal choice for septic shock. As I mentioned, it's our go-to pressor for undifferentiated shock and cardiogenic shock as a bridge to bolster the blood pressure high enough so that the patient can tolerate dobutamine or milrinone. Its strength is that it works through multiple mechanisms, so we get the benefit of higher resistance, increased cardiac output, with less tachycardia compared to other agents, although this still could be a factor. And a major benefit is that we can infuse it peripherally through a large bore IV. I typically start at 10 mics per minute and titrate to a MAP greater than 65. I will add a second pressor around 15 mics per minute and consider a possible third agent at 30 mics per minute. While I recognize that we can go even higher than 30, at this point, or even in this process of escalating doses, I'm really going back and I'm at that bedside of the patient trying to figure out what is happening here. So I'm looking at their volume status. I'm using my ultrasound to get an echo. At this point, I have a central line in. I'm getting the central venous set. And I'm also working to optimize everything metabolically, especially their acid-base status.
Okay, so a good vasopressor for most of the types of shock that we encounter in the emergency department. And I really like this point that before we start increasing the dial of norepinephrine, we should do our best to diagnose and address that pathology that is contributing to the patient's hypotensive state. And this is also an excellent plug for the rush exam here. Now let's move on to vasopressin.
Vasopressin induces vasoconstriction by activating V1A receptors on our vascular smooth muscle cells, so we consider it a pure vasopressor. It is typically used as second line in septic shock, additive to norepinephrine, and this helps both increase the blood pressure or decrease norepinephrine requirements. We use it as a non-titratable drug, so typical dose that I use is 0.04 units per minute. Its strength is its efficacy as a second agent in septic shock, and a concern is peripheral ischemia, though, to be honest, I have not yet encountered this in my practice.
Good, so usually our second line here, and it's set at 0.04 units per minute. It's just an on-off switch that we're going to be using here. It's not something that we're going to be titrating. And it's also important to note that there are some significant adverse effects that have been observed with this medication, but it's going to be difficult for us to tell, is this due to the medication or because it's used in a very sick population? Okay, so that's vasopressin. Now talk to us about phenylephrine.
Phenylephrine stimulates our alpha-1 receptors and causes vasoconstriction. It is good for high cardiac output states in patients with a low resistance. We also will use it in patients with hypotension in the setting of tachyarrhythmias. While it won't directly treat the arrhythmia, it will help support the blood pressure. And we also will use it in patients with critical aortic stenosis. These patients have a fixed afterload and are preload dependent. Other clinical scenarios where I'm reaching for phenylephrine is in the peri-intubation period, either as a push dose or as an infusion. And I'm using phenylephrine in my intubated and sedated patients who are hypotensive really as a result of their sedation and not due to underlying pathophysiology. An important consideration for phenylephrine is that it can worsen the clinical status of patients with a low cardiac output state because, remember, it's increasing the afterload. So while I have this medication ready in my peri-intubation or in my procedural periods, I'm really asking myself, what is the underlying pathology in this patient? Can they tolerate a higher afterload, or should I be considering using another agent?
So good to have it available, but likely there are better options. And this is going to be reserved for patients with high cardiac output states like tachydysrhythmias or patients with AS, and it's also a good choice for most patients who are peri-intubation. It's also important to note that some recommend phenylephrine not be used in septic shock. All right, so phenylephrine's done. Let's round out the discussion with epinephrine.
Epinephrine stimulates our alpha-1, our beta-1, as well as our beta-2 receptors. So we get a combination of vasoconstriction, inotropy, chronotropy, as well as some vasodilation. It's a pressor of choice for anaphylactic shock, and it's second or third line, or I use it as my second or third line agent for patients with septic shock, particularly in patients who develop a septic cardiomyopathy. Its strength is it increases the cardiac output as compared to norepinephrine. A limitation is the tachycardia that it induces, and it can also increase the serum lactate. The lactate is not necessarily a marker of damage, but rather this effect is something that we need to be aware of when using the medication. I typically start at 5 to 10 mics per minute, and I titrate to a MAP of greater than 65.
Okay, so we've talked about norepinephrine, vasopressin, phenylephrine, and epinephrine. Dr. Jamin, can you talk to us about your escalation strategy for the patient in refractory shock and when we should consider stress dose steroids?
In patients with septic shock, my first line is norepinephrine, as we need escalating doses of norepinephrine around the 12 to 15 micrograms per minute. I'll start considering and add vasopressin infusion and also ensure that the patient has gotten a dose of stress dose steroids if they have not already received it. If they continue to be hypotensive at this point, needing a third pressor, often I'm worried about their heart. Again, I'll put the probe on to see, but oftentimes they're not getting enough of cardiac output is what they need. So my third pressor in septic shock is epinephrine. At this point, if I need to go up even beyond the epinephrine, I'm monitoring the entire patient's response. I'm looking at their blood pressure response. How is their heart rate doing? Lactate, POCUS, central venous sat, what's the urinary output? And very important, I look at their acid-base status, because by the time a patient's on 3 pressors, chances are their kidneys have shut down and they're heading towards needing dialysis or renal replacement therapy because they're not going to tolerate regular dialysis. So it's really important to help maintain a physiologic pH.
Perfect. Now we know our medications, how they work, and how to titrate them. Can you talk to us about peripheral pressors? Where are the appropriate sites for running these, and how safe is it really?
The ability to give peripheral pressors is a game changer for our patients. It allows us to more promptly restore perfusion and blood flow to the organs. We know that we can do this safely using large bore IVs that are proximally placed in the arms, meaning the cephalic or the basilic veins, and it's been studied. A meta-analysis of over 16,000 patients treated with peripheral vasopressors reported a very low incidence of adverse events. If it does happen where there's extravasation, then we will aspirate, pull out the IV, ensure, of course, that we've established another access point to be given the vasopressor medication. For the site itself, we'll inject phentolamine and also apply nitroglycerin paste. I routinely use norepinephrine peripherally. So if a patient is hypotensive, I'm not going to wait to put in a central line to start that vasopressor. I'll start it peripherally. And if a patient is steady and does not have escalating doses, I'll leave it and I'll continue to use it through peripheral access. If a patient has escalating doses or is very sick, then while the norepinephrine is going peripherally, I'll go ahead and put in the central line.
All right, now my last question for you, Dr. Jamin. You touched on this before with phenylephrine. When are you giving push-dose pressors?
So, as we discussed, I'll always have phenylephrine ready during my peri-procedure time. It's also a great medication to just have handy. Sometimes patients are not responding as quickly as we want them to while we're starting the infusions, and phenylephrine can be a great bridge to that. If I have a patient where I'm worried about their afterload or increase in their afterload, then I also will have an epinephrine push ready as well. This, albeit, is much more rare in occasion. Most patients are going to respond to the phenylephrine or to the escalating doses of vasopressors that we've already discussed. But if needed, then I'll use an epi push. And you can draw this up. 10 cc syringe, drop 1 ml from the code card epi, as well as 9 cc's of saline, and then you'll have 10 mics per ml of epi.
Perfect. We have a great summary of these essential medications, when and how to give them, along with some pro tips from Dr. Jamin. Let's put it all together with some take-home points. First, the most commonly used medications are going to be norepinephrine, vasopressin, phenylephrine, and epinephrine. And we're going to be considering these medications if there are some signs of end organ damage or dysfunction, if there's a considerable delta in the baseline blood pressure, if the systolic is less than 90 or the MAP is less than 65. Norepinephrine is a good pressor for a lot of the situations that we encounter in the emergency department, such as septic shock, undifferentiated shock, and hypovolemic shock. Vasopressin is commonly the second we reach for in most of these scenarios, and epinephrine will be the first in anaphylactic shock and maybe the third agent that we're using in septic shock. Think about phenylephrine in high output states, so patients with tachydysrhythmias, though we should be cautious in patients with low cardiac output. In general, benefits are going to be outweighing the risk for peripheral pressors in situations where you promptly have to increase the blood pressure while you work on getting central access. Finally, push-dose pressors are going to be there when we need them, so in peri-intubation or peri-code situations when we have to increase the blood pressure and resuscitate before we do anything else. So that'll do it for this episode. Dr. Jamin, thank you so much for being here and helping us tackle this very difficult and essential topic.
Thank you for having me. It's been my pleasure.